Dr. Haack, thank you for being here with us.
It's a great pleasure for me.
Having a time in Barcelona in the Congress?
Till now, yes.
So, till now?
Tomorrow I have to perform live surgery, Ramon, so let's see how it works.
What are you going to do tomorrow then, exactly?
It's a cleft nose, so it's one of the most difficult cases we can face in rhinoplasty, because we have to deal with a lot of asymmetries. And the asymmetries get to be fixed is a great task. So we're going to harvest additionally some rib cartilage to get this extra portion of stability we need to form the asymmetry of the soft tissues. So yeah, but it will be fun. I think we can show a lot of techniques.
I was talking to some of your colleagues this morning, and I was saying that your profession is both medical and artistical at the same time, from one point of view, isn't it?
Do you agree? I agree 100%. I mean, I think if you do our job just under the technical proposes or aspects, most probably you won't reach the best level. You really have to have an eye and feeling for proportions, for some aesthetics. Yes, I think it's necessary in our field. Yeah.
So how do you work with that when you have a patient in front of you for the first time? Of course, the patient comes in with his own demands, but sometimes maybe you have to say, well, maybe this is not the best thing for you. Maybe considering your face, your eyes, whatever, we would do something different.
I mean, this is a good question, because this is everything about patient education, patient teaching, and finding a good way together to work together on the topic, right? So, and sometimes, yes, I take down patients, I refuse patients when they have wishes what are completely not my feeling for aesthetics. And I say, well, you will find another colleague, I won't do it. So for me, it's more getting back to a good normal version of the person. I mean, not like the ideal nose in terms of this angle, this projection, this size, but it has to be a full concept, like of a normal face. So it's also a little bit about reducing bad aspects, not improving things that are already almost perfect.
Does a perfect nose exist?
I mean, when it comes to, let's say, typical angles, projections, yes, most probably there could be something like a perfect nose, but at the end it's a matter of taste, and it's a matter of what you think what fits to one's person. Because, you know, like some people like curved dorsums, having this cute appearance, and some don't like. Even girls ask, I like to have a straight dorsum because I like this little bit more tough look. So please keep my straight dorsum. So it's a matter of taste also.
Mm-hmm. Some of your colleagues were also telling me that in your field, one of the most important things is that you don't actually get to see that the nose has been operated on. That's actually perfect. A perfect nose is a nose that you say, well, it looks nice, but I can't say it's been operated on.
Absolutely. And this is one thing what we in these days see quite often, that noses look pretty good in terms of symmetry, in terms of smoothness, but they look operated because the shape is not natural. If the nose is turned up too much, if the dorsum is too scooped, normal noses don't look like that. There's a small residual hump is much more, of course most people don't like it, most patients, but it's more natural. So yes, this is at least when the patient comes to my office, to my clinic, they like to get an unconspicuous nose. They don't like to see that you recognize that they're operated on. I guess it really depends on your patient collection, because I know there are patients that like to be seen that they had surgery, but in my patient collection, it's true, they don't like an obvious surgical style.
And does this have to do with the possibilities of the techniques nowadays, or with the ability of the surgeon, or both things? Because probably, 30 years ago, I'm guessing you could tell all noses had been operated on because of the limit of the techniques.
Limit of techniques and a different understanding of beauty and aesthetics, and a learning curve of recognizing what looks good like after 6 months and looks good after 12 months must not necessarily look look good after 5 years and 10 years. And so since we are now moving to a longer follow-up period, we see what we've done like 5 years ago, and we like to get a good result after 5 years. You know, like former times technique has been used that it created good results after 3 months, 6 months, because the patient demanded, I had surgery, paid for it, now I like to look good. And now we tell the patients, wait, perhaps in 6 months it's not that narrow or that fine you like to see the nose, but we making your nose, you are, let's say 23, that in 60 or 50 years old, you also have a nice nose. And the people don't like to look like Michael Jackson anymore. Mm-hmm. Directly after the surgery, most probably he'll look rather good, even on his last surgeries, because there was swelling, fibrosis of the tissues. But then the swelling and fibrosis goes down. And then you see the framework. And the framework in former times had been narrowed too much. Of course, immediately after surgery, it already looked good. But then the soft tissues adapt, and then it looks too pinched and gives this typical operated look what we know from the noses from the 80s and the beginning of the 90s, these really little narrow pinch noses. So we don't want to have this in these days anymore.
When we think about rhinoplasty, we tend to think only of the aesthetic point of view, but the function is also very important. When we think of noses, we just think they're there, they help us breathe, but they actually do lots of things, don't they? Yes. And you have to take all these things into consideration when you do a surgery.
Absolutely. So our school, or my philosophy and of my colleagues, is I only operate a nose that breathes well after surgery. So whenever the patient asks for a change where I know it will worsen the nasal breathing capacities, I won't do the surgery, or I really would hardly recommend against this and that step. Because, for example, a patient likes a really narrow, fine nose, has thick skin, and I know if I push everything together, I will downsize the cross-section, and the air will get narrow, he can't breathe. So I don't recommend that. So, but this is a matter of patient teaching, and it's a matter of how you as a surgeon are honest to the patient, and how you think you're still a doctor. I mean, of course, we're playing with aesthetics, but we're still doctors. So our task is really to help the patient on both sides, aesthetics and function.
Yeah. What more or less is the percentage of people who come to you just because of the aesthetic reasons, and people who come to you for, in this case, functional reasons?
So this is I mean, my patient selections that get an appointment with me in my department is selected. So pure function, I only like, let's say, if it's friends or, let's say, important persons, I do pure function. Most of my patients, like 50% are pure aesthetic, and the other one, or let's say it's 40% and 60% is combined aesthetic and function. So they have an insurance part also. It's another story, but sometimes the money thing is also important. So 60% have an insurance part, and then we do additionally the aesthetics on top.
You also work in reconstructive surgery of the nose.
Yes.
Do you feel different when you're operating a nose, reconstructing because someone had a problem like skin cancer or stuff like that? Or is it the same but in a different way?
I mean, the techniques have overlaps, but the major aspect is completely different, because in normal rhinoplasty, we don't have a defect or a lack of soft tissues of skin. But this is what we have in classical nasal reconstructive cases. So there's a big difference. On the other hand, our aesthetic goals are the same. So whenever I do, and this is where it comes together in our department, so whenever I do a reconstruction, I follow the aesthetic principles. I like to get the best looking and best functioning nose I can achieve. And at the same time, when I do my aesthetic work and rhinoplasty, sometimes, if patients had surgery before or trauma, I know all the techniques from the reconstructive work to build up an aesthetic nose, again, like under the surface with a new framework and so on. So from us in our department, it's really hand in hand, it goes together.
Mm-hmm. And you probably also do secondary rhinoplasty.
Yeah,
like challenging a lot.
Yeah, so for me, it's about 45% it's secondary patients.
And in those cases, they come there because of mistakes from other doctors, or what?
Yeah, it's a mixture. I mean, sometimes things can happen and happen to everyone. You can't control healing. You can't control scarring always. You can't control infection always. So some things sometimes just happens, and you just have to deal with that. And yes, sometimes we have to deal with cases where the surgeon before did not make the right decisions during surgery, and then we have to refix it. Yes.
Do you have problems in that sense with people that don't have the actual knowledge to do the surgeries? And then the patients come to you saying, wow, look at what happened to me, no?
That is a good question. I think some people, let's say, still are focusing the wrong philosophies in rhinoplasty. You know, like these days, we preserve more things, we don't cut so much away, because whatever you cut away may cause issues, right? So it's a matter of reshaping, preserving as much as possible. Of course, if there's a huge hump, we have to remove things otherwise, of course. But anyway, keep as much as possible. And some people are still following old techniques. I think some colleagues may underestimate the learning curve. Rhinoplasty is expected to be one of the most difficult procedures in the face, because we have to focus on aesthetics, we have to focus on the breathing. We have different tissues, we have different cartilages, we have soft tissues, we have muscle on the nose. So it's three-dimensional. So it's really one of the most complex surgeries, and it needs a long and good training. It's not so easy. If you just watch one meeting and then you go on next Monday in the OR and try everything, then sometimes it may go wrong.
Yeah. What's the most challenging surgery you've faced during your career? Do you have one you say, wow, that was complicated, but I was very happy because of the outcome?
I mean, one of the most challenging things was really like, I had to do a complete nasal reconstruction, and then after a while we were on a good way, everything went fine, but then she got an infection, the patient, and we had to remove all the cartilages, and then we had to redo in this newly reconstructed skin envelope the new framework, and it took additionally to the planned surgeries 5-6 additional surgeries, and we were really psychological stressed. The patient was stressed, and then finally we made our way through. And yes, these are the hard cases. They really cost you a lot of sleep.
Yeah,
and a lot of hair.
They make you feel fulfilled, and especially the patient must be very grateful for your work.
Yeah, at the end, when it comes nicely and we get a result, then they are happy. Yes.
So just the last question: why rhinoplasty?
This is a really good question. I think the rhinoplasty nasal reconstruction is, when it comes to plastic and reconstructive surgery, for me, it's the core, the fusion of all this, because it's about aesthetics, it's about reconstruction, it's about function, it's about, you can't hide everything, it's in the middle and the face. So it's, for me, this is really the core of plastic and reconstructive surgery.
So you do it for the challenge then?
A little bit, yeah.
Okay, doctor, thank you very much. It was a pleasure.
For me also. Thank you so much.